This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
Hello everyone and welcome to the 1 Million Lives podcast. My name is Michael Sorter. I'm the Chief Learning Officer at Laerdal Medical and your humble host at this episode. Today we have the privilege of being visited by Dr. Nalini Singhal from the University of Calgary. Dr. Singhal is the co-developer of the Helping Babies Survive programs, including Helping Babies Breathe, Essential Care for Every Baby, and Essential Care for Small Babies. These programs have been used to train over 1 million healthcare professionals in 80 countries by now. Just think about that number for another second. 1 million healthcare personnel in 80 countries. Dr. Singhal advocates heavily for the importance of strong local implementation and actually co-chaired an Utstein meeting of experts from around the world to help develop 10 steps for successful implementation of programs like this. She is also the co-developer of Health Child Uganda, a project for improving maternal and newborn health in the country. This approach is now being implemented into districts in Tanzania as well. As you'll hear, she also has a strong passion for what is called immediate kangaroo mother care, and she will talk more about that during the talk. I have to say, I've talked to a lot of people who have many great ideas. This lady speaks from experience. She's been all over the world, and it was creating a lot of enthusiasm in me, hearing her talk about some of these programs, the challenges, but also the opportunities and what a good outcome does. So without any further ado, I'll get right out of the way and leave you with my talk with Dr. Nalini. So, it's a true pleasure to have you here, Dr. Nalini.
Thank you, Michael.
The way I came to learn about you and your work was when I learned that you were one of the co-developers of the Helping Babies Breathe program. And we will get back to that in a second. But I wondered if you could sort of take our listeners and me on a journey to learn what your journey has been like. And with that, I mean sort of what was the path that led you to become a neonatologist and working with saving newborns all over the world, and perhaps with a special place in your heart for the low and medium income countries and settings?
Thank you for that question. I was born in India, and my passion for medicine stemmed from the fact that I thought people that didn't have a lot of resources didn't get the care that they wanted or deserved. For a variety of family reasons and reasons why I had to move after I got married and wasn't allowed to work in the city where my husband worked, I was advised that we should come out and try out Canada, where my husband had a job. And there then I did pediatrics, repeated some of my training, and got interested in neonatology. The interest in neonatology stemmed from the fact that when I was able to help the newborns, I could always see the happy faces of a young family that didn't expect to be in the hospital and sad and now finally was happy, but also could feel that they had, this person had another 70, 80 years of their life ahead of them. And that really fascinated me that hopefully I could make a difference. I then went back to my passion of trying to do something in India and initially started with thinking that lectures were a good idea and quickly found out that that was not the way to go and turned, with the help of the American Academy of Pediatrics, towards developing simple education programs.
Yeah, and I guess those who work in the neonatal field in low-income countries, quite a few of them, I guess, may be familiar with the Helping Babies Breathe program and its siblings. But for those who are not, can you give us a sort of a brief fly-in to the program and why it was developed in the first place?
There was a program, standardized program for newborn resuscitation, and about 10% of the babies that are born anywhere in the world may require some help. And those initial 5 minutes are so critical. They're probably the most important 5 minutes in your life, where if you need the help and you get it in a timely manner, it's a little thing, you're great, you never look back. And if you don't get it in a timely manner, you may either not be there to look back, or if you are, then you are significantly compromised. So these were programs that were being utilized differently in different hospitals. And through the American Heart and through the American Academy of Pediatrics, the standard program, the neonatal resuscitation program, was developed in the 80s. That led me to thinking that what we needed was something simple, because this was a little more complicated and had more, and the simple things would still save a lot of babies. And the NRP committee initially was willing to add something simple and then decided that no, we should develop something separately. And that led to us developing a more pictorial design with the help of some of the Laerdal educators that really helped simplify, and the mannequin that was developed with it, the neonatally, so that anybody who came in contact with a newborn that needed help could provide the help to breathe.
I guess the success from helping babies breathe is now well known in many parts of the world. To me, as an educator, I'm particularly fascinated with how the program and the best practice implementations of it has been transformative in a way that learning outcomes is documented to have been dramatically improved. But I'm perhaps even more impressed with how the program also has translated into very impressive improved outcomes for these newborns. How has that framework also been deployed for the Helping Mothers Survive program and the Helping Babies Breathe Survive curricula altogether?
When we developed it, we were trying to develop a simple pictorial design, but not only that, incorporate the scientific evidence from how learners learn from simulation and not separate it out from the clinical, so incorporate it without actually sounding like we were training with simulation. But what we found was the interactive, hands-on, small group learning allowed people to learn much more effectively. And because we found that with Helping Babies Breathe when we first field tested it in Kenya and in Pakistan, it became quite obvious to people. And that's when Japaigo said we want to try and develop the Helping Mothers Survive series with similar objectives. The other part of it was that technology is not easily available in the low resource settings, so you don't always have the ability to use slides. So this was a very simple, hands-on, low-tech program where you didn't need any electricity, you didn't need any slides. You had a flip chart, and the flip chart was everything that you needed, and the neonatally with it. And at one time, when we released it after 2010, I was in Uganda, and actually, because the electricity was off and it was really dark, we went outside, sat under a tree, laid out our things, and we did the training under a tree.
That's pedagogy for you. I've heard you speak multiple times about the potential in peer-to-peer learning. And I'm wondering, what is your fascination with this methodology?
So when we look at how we want learners to learn, we need somebody to help them, and we need somebody to help practice, because you learn it once, but then you still need to go through the scenarios again. For you to be able to do it at 4 a.m. when nobody's there. You shouldn't have to think, it should just come automatically, and you need a certain level of practice to get there. However, if you practice alone, you don't know what you're doing correctly and what you're not doing correctly. If you wait for Michael to be able to come and train, how many places is Michael going to be able to go to? And so then I started thinking that, if we give them the tools to practice on their own, we all know that nobody does everything well and nobody does everything badly. Everybody does some things well and some things not so well. And so if we learn from each other, which is a principle that we had used in Canada for improving neonatal care, then you learn from your peers in a non-threatening, respectful environment, which will allow you to practice. And that has stayed my fascination with peer-to-peer learning, because the students, the learners like it. They can do it whenever they have the time. You don't have to book workshops. It's low cost, but more than being just only low cost, it empowers the learners to learn from each other and to help each other, so that if something is not going correctly in the delivery room, they're not scared to come back and talk about it and say, we got to do this better next time. So I think it does encompasses all those things, and that's why I'm very fascinated and supportive of peer-to-peer learning processes.
And I share your fascination with this as an educator. I think this is heavily underutilized in the education in general, but also in the professional sphere. We seem to believe that there needs to be a person with the knowledge in the room, but there are, of course, many different ways that that person can be represented in the room without actually being there physically. And that's really what you did with your program in a very nice way. And it brings me to the program Helping Babies Breathe. It was developed more than 10 years ago now. And it has since been refined and improved in iterative stages to a point where it's now also integrated into the WHO Essential Newborn Care course. I'm curious, what have you learned along the way that has been integrated into this program?
So there are two parts of it. One is, some of the science changes as you go along. So you can emphasize slightly different things to make sure you're up to date with the most recent scientific recommendations. The second thing that we've realized is that this is an education program only. And you can do peer-to-peer learning and quality improvement, but it's still education only. So what we tried to do with the second edition of Helping Babies Breathe is to include some quality improvement indicators, which people could use related to the action plan that we had, so that you could find out how many babies were blue or how many babies were breathing at the right time and things like that, and make changes. So what we've learned along the way is, if you go back and look at the Utstein formula, we've got the science. We have not all of it, but we've got a lot of the science. With Helping Babies Breathe methodology of helping a learner learn, I would like to stay away from teaching. I would like to focus on the learner being able to learn. We've got it down quite well. And we've got methods now of the learners retaining their skills, but we haven't been able to focus, which we would like to do now, is to focus on the local implementation. And that would include both the clinical and the education. The education has done quite well, that it's rolled out in a lot of countries. A lot of people have been taught how to do it. And a lot of lives have been saved. But we need to move to the next step, so that yes, we may have saved 50% of the lives that we could save, but we've got another percentage left that we need to address. And I think that will come with more emphasis on local implementation. And so combine that with peer-to-peer learning, I think we're on the right track.
The numbers you speak of are phenomenal. I mean, you've trained more than 1 million healthcare workers, and in 80 countries. I mean, any program would consider that a huge success, but you are one of those who focus on the outcomes of this, and so I completely get that novel approach of trying to combine the training with quality improvement. Could you unpack that a little bit further? What does it look like in the program? What is to be learned about that mix in the program?
We're learning, and we're going to take a little more time to learn all that. Well, one of the things we've tried is these days, kangaroo mother care, there's a big push for that. So what we did with a small grant is decided that we were going to include quality improvement. Quality improvement, again, has to be unpacked, just like resuscitation was simplified for helping babies breathe. It wasn't something that some expert did. It was something that everybody could do. It's the same with quality improvement. We've been able to now simplify it enough, I think, with some of the programs we have in Canada, that every bedside nurse can do it. Not a long 6-month or a 2-week program. It's about a 6-hour program, and there are some simplified quality improvement programs out there. But they, again, are a silo. You do a quality improvement program, then you do a clinical program. So what we wanted to do was to combine the two, is to say, no, we're going to do both of them and we're going to integrate them. So for the kangaroo mother care that we're trying to implement in some of the countries, the exercises that you do are related not only keeping the baby warm and how do you do that, but the exercise also is babies in your unit are cold. How are you going to address that? And so we take you through the steps of developing a quality improvement program simply in your own unit. And we found that quite successful in Uganda, where in one of the hospitals we did it, and they found that it was really empowering for the nurses and for the families to be able to continue to make the changes, so you don't need a physician or senior administrator to help you.
That's where the link, for me at least, to what you said about local implementation lies, or at least part of it. And I'm really curious as to when you say that local implementation needs to improve, does that equal that quality improvement part, or are there other things to it?
No. There's a lot of the local implementation has a lot of different aspects to it. And so if you take the example of either helping babies breathe or KMC, there has to be a readiness. So if you take KMC, you've got to have a place for the mother to eat. You've got to have a place for the mother to go to the bathroom. You've got to have the administration supportive of what you're trying to do. You've got to have your staff bought into the process that you're trying to change before you start implementing programs. So you're not only looking at physical equipment and space and readiness, you're also looking at human readiness. But on top of that, you're also looking at the families have to be ready. So you've got to be educating the families for readiness. And once you have the package of readiness at different levels, then you're ready to implement the program and you'll see it successfully. So local implementation then becomes all of these, including the administration. So it's everything that's going to affect the mother and the baby, from the mother becoming pregnant to taking a healthy baby home. All those levels have to be addressed before you start implementing, before you'll get change.
And that is such an important point, because it sounds to me like you're advocating a bottom-up approach.
Yes.
To some degree. Some of it needs to be top-down, but a bottom-up, where those who are closest to the problem should be enabled to work on the problem and fix it.
This is a 1 Million Lives podcast by Laerdal Medical.
I'm also curious as to, because I have to admit that I've been hearing that some places where part of the initial immediate KMC or immediate kangaroo mother care initiative, they got the results, but they actually gradually went on the slippery slope back to the old practices. So I'm curious, how can we sustain an implementation over time? What is it that makes it stick?
So the reason they went back, part of the reason they went back, I think, is resources and the money that was being put into research, which is always an issue when research ends. You don't have the extra resources. Part of the reason was, I think, is that they were not convinced that it was as safe as they would like it to be. Part of the reason is that we didn't actually get the families demanding it. So when I was speaking to people here, I said, there are multiple ways of trying to address it. One is to increase demand. Let's educate our families on the importance of it. They're going to ask for it then. And then the medical establishment is going to have to respond to it. The second is, when we try to make change, let's not try and make the change completely like the research was done. For example, I'll give you an example of what I did with cord clamping in Canada, in my city where I was responsible for about 20,000, 25,000 births a year. And, if I told them to do delayed cord clamping on all the babies, I was going to get pushback. So I said, all right, what we're going to do is we're going to spend the time, just like local implementation, I was going to spend the time 6 months talking to everybody, asking them what their concerns was, answering their questions. But then when I was going to implement it, I was going to implement it in a stepwise fashion. So I said, okay, we'll take the 32-week babies and above and do it in those. Are we okay with that? Yeah, we're good with that. So when you do that, they get used to it. 4 weeks later, I was being pushed. Why are we clamping the cord early in a 28-week baby? You told us it benefits all babies. And if we do the same with KMC, start immediate KMC in all the stable babies. Let's not worry about the ones which have respiratory distress. That is a lot of babies that will benefit significantly. And as you get more comfortable, it's not a huge change. And then people will be ready to move down. But that, I think, is related to human behavior. Unless we address it, we're not going to succeed. So that's what I would try.
Yeah, and I love how you emphasize the behavioral side of this. Most training sessions, I guess, will by nature be somewhat artificial in their setup. But I guess it's a little bit like fake it until you make it. If you can get the desired change in behaviors, the way we work together, and the way we address problems in clinical care, I guess it's different. It needs to get under your skin in a way, and it's fascinating, this thing about creating a desired change and then sustaining or trying to sustain it over time. But I would like us to zoom out a little bit and focus on the Sustainable Development Goal number 3. 2030 is coming fast, and the SDG 3 has set some very ambitious targets for reducing neonatal mortality to 12 deaths per 1,000 live births by 2030 in all countries on the planet. I'm curious, Dr. Nalini, how would you gauge our results so far? How are we actually tracking on this as you see it?
I think we need to make a lot of changes if we're going to get there. If we keep doing business as usual, we're not going to get there. Part of the change I think that needs to occur and needs to occur very quickly is rather than doing these things in silos, like simulation, quality improvement, helping babies breathe, essential care for every baby, sick baby, kangaroo, I can go on and on and on. It's one person who's taking care of this baby. So we need to empower them and do it in a comprehensive manner so that the quality improvement and everything is an integral part of it. The second part of it that needs to occur, which is even more important, is healthcare providers should not be providing healthcare to the babies. The families provide the healthcare. Our job is to help the families provide the care, not to take over the care, which we've done for so long. So we need to, as healthcare providers, change our mindset very quickly. And imagine the amount of resources you will have, human resources you'll have, if you allow the families to provide care for their babies and you help.
And they are so motivated, of course.
Absolutely. They've got a much more of a reason to provide the best care to that baby than we do. They're going to be very good at it. And they are very good at it when we allow them and we empower them. So just like we started from neonatologists and physicians trying to empower the nurses, it's time to empower the families and transform care of the newborn in the 21st century to the families providing the care and the healthcare providers helping the families provide the care. So if we can do that, I think we'll meet our goals.
But I guess for some countries, that is probably a bigger paradigm shift than for others. What are the inhibiting factors here?
We've got a lot of inhibiting factors, so it's going to be an uphill battle.
Yes.
And the inhibiting factors are, number one, inhibiting factor is going to be physicians. It's like, the days when you would say the baby's in intensive care, the family shouldn't be coming in, it's intensive care. Okay, so that's one inhibiting factor but we need to change their mindset. Second is obviously going to be the ability, space for the families to be able to do that. But it's still manageable. It's not an unsurmountable difficulty. The third is going to be for educators to actually, like yourself, to help put these programs together, which are simple enough and can be built on. So you can start simple and you can start with this, but then if you want a little more, here's what you can do. And not have the programs separate in different silos. And I think the educators are starting to think like that. So it'll still be an uphill battle, but it still might be, it has to be doable. We've got to have the families providing the care and us helping in a comprehensive manner. So I can't run away from it because that's what needs to be done.
Exactly. And I have sort of coming out of that, I have a question I ask all the guests here at the podcast, and that is, what role do you see technology playing in this? And I'm not thinking necessarily digital technology, but all kinds of technology. How can it be of help, of service to us?
So there are lots of ways technology is going to help us. But we have to remember that as we develop technology that is going to help us, we always need to remember that technology may not be available to everybody. So we owe it to the babies and the families to have parallel systems. Just like I said, you can teach helping babies breathe in an air-conditioned room, but you can also do it under a tree. Having said that, technology is going to help us in education, in maintenance of skills, in people being able to practice with peer-to-peer learning. It's also going to help us in quality improvement because there's no quality improvement without data collection. And we need to find a simple bedside way of not a complicated medical record of collecting simple data that can be fed back in a timely fashion so that quality improvement projects can go on. And for example, if you have a smartphone and you collect the data on the physical examination of the newborn quickly, it's not very time consuming. You may or may not be connected to the internet that day, but 3 days later, when you do have internet, it can upload it. So we've got all these things. I mean, we can go to the moon, we can send things to the Mars, we can definitely try and manage some of these things, keeping in mind that electricity is not going to be consistent. Internet is not going to be consistent. So if we develop technology keeping those things in mind, how to get around them, and the technology experts can definitely do that, it'll move us forward in the right domain. And the last thing technology can help us with is when you provide timely information, it makes people feel good that something is working out well and they're going to work harder at it. So technology can be very helpful in doing that and getting our messages out to the families. So there's a lot of ways technology can help.
Yeah, and let's be mindful, I guess, about how we use it, but use it for good. I like to think of myself as an optimist when it comes to educational potential and technology, but I'm also not blind to some of the ethical problems, of course, and data flowing and so on. I guess it's fair to say that you have more of your career behind you than in front of you. I even heard rumors that someone said that if you wanted, you could probably be retired now, but you choose to go on. Why is that? Why are you still engaged?
Well, I think retirement is not the correct word that should be around in the English dictionary. People should be looking at retooling, redoing, realigning, something different. And clinically, yes, I'm not going to be resuscitating a 24-week baby anymore. However, I am convinced that if we keep working hard on simplifying and packaging things, we will get to our goal. And my passion is that every baby in the world, no matter where it's born, gets the same advantage of being able to grow up and have a healthy life. And it's a laudable goal. It's probably not going to happen. However, the closer we get to it, the happier I'll feel. And right now, we're not there. We're so far away from some of us being so fortunate and some of us not being so fortunate just because we live in a different part of the world. That keeps me going.
You're leaving us on a sort of a high note, but also with a challenge.
Yes.
And I like that a lot. I thank you so much, Nalini, for taking the time to be with us. You're an inspiration, like my old mentor, Harald Eikeland.
Yes, I know him well.
I know. And he's also one of my inspirations. I know you collaborated on the Helping Babies Breathe in the early days.
Oh, yeah. He told me with one slide, he put in word, like 100 times and said, you can't do that. All right,
exactly,
won't do that.
Exactly. Oh, that's so right. Thank you so much for your time and for coming to Norway around. We are recording this now in Norway because you're visiting here and sharing your insights. And to all our listeners out there, I'm sure you can hear the passion around this topic. And we all need to join that sort of movement of doing whatever we can to help save these newborns so they can have a prosperous and healthy life. Thank you again, Nalini.
Thank you, Michael. Bye-bye.
There you have it, ladies and gentlemen. From one of the leading experts in the world, neonatologist Dr. Nalini Singhal. If you are like me, I'm sort of a bit lost for words right now. What she's telling us is that there are some very effective steps. We know what they are, and we need to implement them. And she points to implementation as the weak link in this chain. And I guess we can all relate to that. We can have great ideas, we have the research, but how do we implement? And that was what she was trying to get us to focus on. I'm inspired, and I hope you guys are too. If you have any comments to this or have any ideas for future podcasts, do not hesitate to contact us on podcast@laerdal.com. That is podcast@laerdal.com. Thanks for now. Thanks for listening. And to make sure you get future episodes in your inbox, just hit the subscribe button in your browser and you're good to go. Thanks for now. Bye.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.